Any questions from the audience following Cecilia's talk? I mean, whilst you're thinking, we've got two here. Microphone? Whilst we're getting the mic over there, when you look at the growth, there seems to be quite a significant split, as you said, from CRL. You've got miscarriages where they grow normally and miscarriages where, and there seems to be two groups, quite clearly, and perhaps two mechanisms, who knows. When you look at the MSD data, there seems to be a huge amount of overlap between subsequently viable and non-viable pregnancies. And based on that, then, what's the premise of if you have an empty sac of repeating the scan? What are we looking for? We repeat the scan a week later. Are we looking for it to grow, or what are we doing? Because it would seem to me that it doesn't mean anything.
I think that's absolutely right. There's an awful lot we don't know, that in women who have an arrested pregnancy with an empty gestational sac, sometimes that sac is going to continue to grow, and sometimes that sac is going to remain the same size. And I think we don't understand the pathophysiology around that. In those where you're not sure about the viability, so certainly in the UK, the sort of standard criteria is an empty sac of mean sac diameter, and that really means mean sac diameter. It means taking all three measurements and taking a mean, and that's less than 20 millimetres. Then our guidelines are that you rescan in an interval of no less than 7 days. But I think, I'm not sure if what you're referring to is what happens then. So we may see absolutely nothing within it, in which case we may say, look, this really is a miscarriage. We may see a slight growth in the gestation sac. We may see a yolk sac at that stage. We may see a very small embryonic pole with or without a heartbeat, with or without a yolk sac. And I think we don't know which of these pregnancies are continuing to progress and they might become viable, and which might become viable but then fail later on, and which might become viable and go on to be absolutely normal pregnancies. And we make a lot of assumptions that just because we don't see a heartbeat, that means it's not okay. And I think that, as you know, needs to be tested prospectively with trials looking at managing these women expectantly.
Thank you. Whilst we're answering the questions, we've got could Siobhan, Steve, Yazan come up and sit here for this round table, please, if that's right. Or Steve, don't do that. Stay there. Next question.
Yeah, Manika from India. What I want to ask is that how many ultrasounds on an average you would do to come to this conclusion that this growth is satisfactory or not? How many scans in the first trimester on an average would you do?
The answer is that's not quite how it works. All this data is taken because we have the benefit of having early pregnancy units where women do come in for scans anyway. So all of these women in these studies were not brought in for the study. They were women we were seeing and scanning anyway. I think, but it's a research tool, so potentially to look at it, then for the FLDA technique, you would need to do 2 scans in a row. So say 6 weeks, 8 weeks, 7 weeks, 9 weeks, and then you get a good idea about that. But for the cruder test of just the cross-sectional data, you could do it just on the first viability scan.
Just to add to the discussion, I think the really helpful thing about your data is the other way around, is if you are growing, is it 1 millimetre a day, you said? If it was growing 1 millimetre a day, and ultrasound scans are good at reassuring people, you can say that to them. I'll remember that, but I say, oh, you're doing marvellously, it's grown a lot.
Yeah, so 1.2 to 1.4 millimetres a day. Yeah.
I think we should do it the other way. I've been to the conference in London. You've grown your 1 millimetre a day, you'll be fine, because, the stress of someone miscarrying is so high. We need to give people positive miscarriages in the lack of evidence. So I think you should take her presentation completely round the other way. 1 millimetre a day, you're fine. Would that be all right?
It would, but you can't forget those who miscarry after normal growth as well. But you're right, it is and I often say that to people, it fits exactly with your dates, and for the ones where it doesn't fit with the dates, you have to be cautious.
Steve is bursting at the seams.
Maybe we should have had this panel on defining, how do we define miscarriage before we had these presentations, because I want to say that I think we're dealing with a large number of events and etiologies that have a final common pathway. To the patient who has a pregnancy failure, she's miscarried. But there are so many different etiologies to get to that point, and I think even we're mixing many of these things up. We now have patients who can diagnose a pregnancy event at the time of the missed menses with these home, over-the-counter monoclonal antibody pregnancy tests. The White Journal, it was years ago that the White Journal started to publish these articles on early anomalies in fetuses of 10 to 14 weeks. that made me realize that we need to get rid of the word first trimester. The first trimester was an invention. We divide pregnancy into trimesters. Why? Think about it. There is absolutely no reason why the first trimester should exist in terms of anatomy, development, or risk of loss. Instead, we should be thinking of an embryonic period and a fetal period. The embryonic period ends at about 10 weeks LMP, when basically organogenesis is complete. The fetal period begins at 10 weeks LMP, when we go into a whole nother stage. And the ability to detect pregnancy at the time of the missed menses gives us a new entity called chemical pregnancy, where we have a transient rise in HCG, which then goes away, and we never have any other thing other than biochemical evidence. Yet to our patients, a failure in any one of these categories to her is a miscarriage. And yet I would put forth to you that the etiologies, that the counseling, that the expectation for future pregnancy should be very, very different depending on which of these three categories the pregnancy loss occurs in. And I think that's what we need to be framing this as. I would agree, a lot of these, I've stopped giving aspirin 15 years ago because we realized that some of the late, what you called first trimester losses, are actually the beginning of placental separation. Women who come in staining may have a placental problem, and aspirin is going to do nothing but make that worse. I think that we found out years ago, and you showed it very nicely, that the thrombophilias cause all kinds of problems later in pregnancy, but they are not a source of what I consider to be early pregnancy loss. My field of interest ends at 10 weeks LMP. The embryonic losses, and there's great evidence that at least 70% of these are karyotypically abnormal. And you pointed out quite nicely, there's no point in giving a karyotypically abnormal pregnancy any kind of supplementation. Nature's much smarter than we are. Trisomy 21 is the healthiest of the chromosomal abnormalities. It survives. 18 and 13 sort of get to term often. But as you correctly point out, there are trisomies of every numbered chromosome. You've got triploidy, you've got mosaics. Most of these do not survive, and it's a good thing they don't survive. So, and in the chemical pregnancy stage, the last point I'll make and then turn it over to other people, I would refer you to an article by Wilcox, which is more than 20 years old. Wilcox did an amazing study, which I find very helpful in counseling patients. He took 221 women, mostly nurses and nursing students, who were attempting to conceive, and he was doing daily urinary chorionic gonadotropin before we had the sensitive home tests we have now, from 8 days LMP. 22% of the women who had a transient rise in HCG levels reflected in their urine bled at or around the time of the missed menses. Now, he dubbed these chemical pregnancies, but of these patients, 35% were clinically pregnant the next cycle, 65% by the third cycle, and 83% by the sixth cycle. This is an excellent prognostic sign. It means they ovulate. It means they capacitate their husband's sperm. It means at least one tube is open. And so the woman now that we have these sensitive home tests, who has a positive home test on Sunday, has staining on Tuesday, presents herself to us. We ultimately diagnose a chemical pregnancy. She mourns the miscarriage that she has suffered, and yet she needs to realize that her chances of having a clinically recognized pregnancy in the next 1 to 6 months is infinitely better than her friend, sister, co-worker who wants to be pregnant, who's simply getting her period month after month after month.
I can see how your private practice does so well now. You can, my God, you can sell that to them. That's really impressive. Sarah, can you cancel his expenses? Because he's just not. I'm going to stop you there. I just was concerned to stop you because he hadn't actually taken a breath for about 3 minutes. I
was busting, right?
Yeah, yes. Well, that's just your age, Steve. Don't worry about that. I want to move on to diagnosing miscarriage and have a little chat about that because although Cecilia sort of touched on it, and since you're standing there, as it were, I mean, there does seem to be some disparity between different countries about, I mean, you talked about inter-observer variation, quite significant in terms of mean sac diameter and quite worrying. And it would be interesting to know, what the feeling is around the panel of, what criteria should we use to diagnose miscarriage? Because I'm slightly concerned because we've had discussions with Steve before, and I think Steve would say, and I would agree, that most of the time you can see a sac, and actually quite a small sac. There's soft markers. We all can see pregnancies where you think, it's just not going to work, and you're going to get it right most of the time. But most of the time isn't good enough. If you're going to make a diagnosis of miscarriage, it has to be right. And yet we have variations in cut-off values for MSD between actually 12 and 25. And similarly, we have differences in how often you repeat scans. And I don't know anywhere else in life where you make a diagnosis of people being dead based on such sort of soft information, really. I mean, if you're on ITU, you'd say, no, I don't know, he's probably dead, switch it off. I'm not sure how well you do terribly well in your clinical practice if you had that approach. So can you kind of kick off, really, and to say your view?
It's really interesting because I said to our breakfast group that it's the thing that we do all the time. In early pregnancy, we break bad news to people more often than any other medical specialty altogether. And yet, we have such poor criteria for making the diagnosis of miscarriage. The reason that the criteria we use exist is because of the investigation into cases of pregnancies which were terminated or nearly terminated, which in fact turned out to be viable, having initially been told they were miscarriages. And the worry is that this is happening all around the world all the time because the people are not using evidence on which to make the diagnosis of miscarriage. So, as I say, we use a crown rump length of 6 millimetres without a heartbeat as a diagnosis of miscarriage. If it's less than 6 millimetres, we always bring them back and rescan them in at least 7 days. Other places have published that this can be 5 millimetres, that this can be 4 millimetres, and some people say they use 3 or 4 millimetres. The problem is, if you look at the evidence, it is small, retrospective studies of 25, 35 women in each.
Are you looking at Steve here?
And I'm looking at you because I know that you've looked at the numbers just very recently.
That's fighting talk, Cecilia, I reckon.
I'll look at Steve. But the fact is that people who are using cut-offs of 4 or 5 millimetres to diagnose a non-viable pregnancy will be right 96, 98% of the time, maybe even 99% of the time. But they won't be right 100% of the time. And we know this from the work we've done of pregnancies that have gone on to be viable with CRLs with initially no heartbeat of 5.5 millimetres. Now, we'll have people who say, I absolutely know that this is a crown rump length of 4 millimetres and no heartbeat. That pregnancy is not going to be right. And as I say, they may be right 99% of the time, but in medicine and in early pregnancy, you have to be 100% right.
Cecilia,
There's no harm in waiting.
I was going to say, unless you're intervening the next day, what difference does it make? If you get another scan, I think the combination of growth over time, and in other words, if you had that unusual case where you've got a crown rump length of 4 millimeters and there's no cardiac activity, and the literature would suggest that that's non-viable 100% of the time if you look at ABAD.
The small amount of retrospective literature.
But I'm saying, and you say to yourself, well, but this may be the 2 or 3% where that's not accurate. So you bring her back in 3 days. She ought to grow 1 millimeter a day, and by that time she ought to have cardiac activity by anybody's criteria. I only see this as a problem if people are intervening the very next day. To me, the big divide is once you've excluded ectopic pregnancy, which is potentially a life-threatening situation, then this debate about diagnosing a failed pregnancy, if you're not intervening, it'll declare itself.
Well, but you still have to say something to a woman. You have to make your diagnosis or not. And you have to decide.
I think, Steve, but the point is people are. I mean, I accept your point. I mean, I think the thing is that in developed countries anyway, certainly, the management of miscarriage has changed, and an awful lot of marriages expectantly. And you're not going to do a lot of harm by sitting there, whatever, and doing nothing. But, and it certainly happens in the UK, there are a number of situations arise where women, we see them. They come in, they've been told they've got a miscarriage based on one measurement of mean sac diameter, which actually isn't a mean sac diameter because they've measured the same thing 3 times. And we know there's a significant... No, but it happens in real life.
I think you're touching on a very important point. Serial observation. And it's not just for diagnosis of miscarriage. It becomes so important for the diagnosis of potential ectopic pregnancy. I mean, the biggest cause of lawsuits now in the States is the use of methotrexate on a single visit to an emergency room where they think that there's no intrauterine pregnancy. They were nervous about ectopic. They gave methotrexate, and 3, 4, 7 days later, there's an intrauterine gestation with a heartbeat, and now she's had methotrexate. So the key word that you said, I think, is serial observation. In a patient who is stable, like with one intervention, you'd be very foolhardy to do too much based on that intervention. I mean, absent a beating heart in the adnexa, obviously. But
No, but David, I think the point you make is a very good one. Yes, I mean, can I bring you in? You've been looking at cut-off values for MSD. Do you have a feeling for what, if you use different cut-offs, what your performance would be in terms of diagnosis?
Yes, exactly. Well, like Stephen said, serial assessments of the pregnancy in the early stage, especially with an MSD of less than 20 and a CRL of less than 6, according to our guidelines here in the UK, are very important, and they lead us to safe practice. However, what we are here discussing is when these measurements, when we're talking about decision boundaries, especially in the UK, the practice here is that you are allowed to make a diagnosis of miscarriage based on a single visit. When an MSD is 20, a CRL is 6, and there's no fetal heart activity. We set out to test this because, like Tom said, this is potentially a termination of a viable pregnancy. Yes, it's a fetus, but it can be very, very precious to a woman with multiple recurrent miscarriages. We set out to test this, given in the background the important findings of what Cecilia has presented to us, the work our group has done on the inter and intra-observer variability that showed that around 20 millimeters mean sac diameter, there is a 20% variability, which means that if one of us who do very regular ultrasound scanning here measures a sac of 20 millimeters, mean sac diameter of 20 millimeters, that can be from 16 to 24. Now, Stephen has contributed, has led one of 2 studies that formed the American guidelines of diagnosing miscarriage, with a study of about 40 cases that led to a standard practice in America of diagnosing miscarriage when there is an empty sac of 16 millimeter with no embryonic structure inside.
I'm going to stop you. At 16 millimeters, given your data, what would the false positive diagnosis of miscarriage be?
Exactly. So we set out with our data, we used above 600 cases around these decision boundaries, and 16 millimeter would be associated with about 2.7% false negative rate.
False positive rate for miscarriage?
For miscarriage.
Right.
False positive
and
rate.
18 millimeters, about the same?
18 millimeters, about 1.6%. I do not have
20 millimeters?
20 millimeters is shocking. It's still 0.8%. Yes, it is less than 1%. However, there is a false positive rate.
So there is a false positive rate if you go. I mean, I'd be interested. Can you put a yes no up on the screen, please? Just out of interest, I mean, has anyone or would anybody, given the fact that certainly the esteemed Royal College, which Siobhan loves, clearly, English, can allow you to diagnose miscarriage on a basis of one scan with an MSD of 20. Is that the basis of people's practice? Do people use ultrasound in that way and say, I'm very sorry, your gestation sac is 22 millimeters, I can't see anything there, or whatever, it's a miscarriage, and then manage them on the basis of that, irrespective of whether you bring them back or whatever? Is that what you tell the patient? Can we have a yes if you do or no?
Want to bring up what kind of equipment you're using? Does that matter to anybody? I mean, I think there's been good evidence that when they talked about 13 millimeters mean sac diameter 15 years ago, when people's vaginal probes were 5 megahertz or 6.5, now we've got these variable 5 to 9 megahertz transducers. I think some of your ability to see a yolk sac within a gestational sac is going to be transducer dependent. The other thing I've heard nobody mention is this is a technical modality. If the uterus is axial, if she weighs 250 pounds, if she's got a coexisting myoma, if she's had previous surgery, your ability to see structure may be different.
Yeah, but we don't have women of 250 pounds in the UK, Steve, you know?
Okay, you know, what?
Come on.
Go ahead.
Go
All right.
Take a walk through Hyde Park, Steve.
Come to Iowa. All right.
Yeah.
They all moved to the States.
Yeah, we know.
We feed them better.
You have to set, well, hey, come on.
I saw McDonald's on the way in from the airport.
Yeah. So, it would appear that we have 32% are using cut-off values on the basis of one scan, which, I mean, it's absolutely reasonable because those are the guidelines. But it does illustrate the point, Steve, that people, and I presume that people will perhaps not even say that, given the discussion that's been had. So there is a constituency of clinicians who are using cut-offs, so it's really important that we get it right. And I think the message is that from what Yazan and Cecilia are saying is there is inter-observer variability when you measure these things. So if you do measure 20, and this was with experienced operators, you've got to have a margin, you've got to be sensible. And if you do use cut-offs of 16, 17, 18, yes, most of the time you'll get it wrong, but every so often, most of the time you get it right, but every so often you'll get it wrong, and 1% is too much. Steve's point about repeating scans and interval is absolutely vital. And it doesn't actually, it can be early pregnancy, it can be the endometrium, which I know you're going to talk about, it can be looking at the ovary. Ultrasound is a dynamic process. And sometimes you have to manage patients' expectations and say, well, I'm sorry, we can't make a decision now. And there's always that pressure, isn't there? You know, patients want to know what's going on. That's the biggest problem, I find, is that it's like, do something, doctor. And you just say, well, actually, no, go away. And the trouble is, they go and find someone who will do an evacuation of their uterus.
Can I ask?
Oh, Nick.
Yes.
Nick Fenning, the one with no brain, if you remember from the CT. So don't expect much, really. It's not going to be good.
It looked like a foreign body in there, though.
Your research fellow is holding your microphone. Is that how it is? Oh, Nick.
Proven. Have to switch it on as well. Shamli reliably tells me that we haven't asked patients what they feel. Has there been a study whereby we will ask what is acceptable to patients as a false negative rate? Do we know? Could you put your yes and no back up then? And can we ask the audience, so the same question you were asked about how you would manage the patient with a mean sac diameter of 20 millimetres. Now I want you to answer the question as if it's you. So it's your pregnancy or your partner's pregnancy. So would you accept that pregnancy is non-viable on that scan result, or would you want a repeat scan in a week? So the question is then, for a yes, is would you be happy that your pregnancy is non-viable with a mean sac diameter of 20 millimetres, and you are the patient?
Answer yes to that, or no if you don't.
And Maria with us will probably give...
And those of you, depending on the answers, you can have an appointment with Maria Jalbrandt's clinical psychologist here. Who private practice address is in Sloane Street. Right.
So double standard.
Interesting.
Double standard.
The crass hypocrisy of the medical profession strikes again. Right.
Can I ask Siobhan a question though? I loved your talk. There's a couple of things though that weren't.
Shabana.
Yeah.
Who?
What's your first name?
Siobhan.
That's what I said. That's what I said.
Don't worry, you call her anything you like. It's
English,
fine. You know.
Just different English. Couple of things that I think weren't mentioned that I'm curious to know about. One is infection. You didn't mention infection with T-strain mycoplasms as a source of recurrent pregnancy loss. The other thing has to do with uterine abnormalities, like I think certainly incompetent cervix is much later. I think that septation is probably a continuum, septum in the uterus. Submucous myomas, in other words, you went into certain areas, but there were some areas that you didn't touch upon. Can you comment on that?
Yeah, go on, because I want Nick to talk about that as well.
Okay. So if I just answer the one about infection. So basically, I've now looked at at least 1,000 endometriums from people with recurrent miscarriage. So my argument is if you had a chronic infection, you'd see a chronic inflammatory response. And I see it about 1 in 1,000. So in my practice, it's rare. But when we had my breakfast talk this morning, there are people in the room who work in areas where you have subclinical TB, which I think is more likely. And we have a high immigrant population here. So I think it's important, but rare cause of miscarriage. And so I now have patients who come to the UK with that. And there are people who come to the West or in all your practices around the world who have subclinical tuberculosis as a cause of reproductive failure, and it's easy to treat. So I think you've asked a very important question, but you need to know the prevalence in your community as to whether to answer it. And then the uterine abnormalities, Nick will answer.
Nick,
When you stop talking.
do you want to comment on that? Because Nick is currently planning a trial, which is, I think, is incredibly smart to have thought of this novel. He's calling it the septum trial, really, which is wonderful. Very, very novel term for the trial.
You don't get money unless you have a good acronym.
You need your acronyms, don't you? Yeah, go on.
So I'm going to talk about this tomorrow, but the evidence is unclear. It's probably a fair summary. If you look at the quality of the studies that have been done, there are very few really good quality studies. But there does seem to be a link between miscarriage, both first and second trimester miscarriage, but probably even more importantly between septums and preterm labour. But the link is not that strong, and it's the same is true for submucosal fibroids and pelvic pathology in general. And as Siobhan has said, with NK cells and thrombophilias, there are a significant portion of women, the majority, will be fine. And the most important factor is we do not have any randomised controlled evidence of treatment. So even if we accept there is a risk, we can't tell the women what the surgery will do to that risk. And we can't say that it's safe. And the same is actually probably true even of myomectomy.